Now we come to the airway assessment. The evaluation of the airway is the most important and vital skill which every anesthetist must acquire. With repeated assessment of patients, anesthetists should be able to anticipate the level of difficulty in the airway and learn the skills to manage them in proper evaluations and planning of the airway can save a life, patient's life. The normal intubation position is sniffing the morning air. In a sniffing position, there is an extension at the atlantoaxial joint and flexion at the lower cervical joint. This position brings the oral, pharyngeal and laryngeal axis in line to ease intubation. The evaluation of the airway by anesthetists should follow a proper sequence so as not to miss any component of the airway, which can later on complicate the airway management. This can be achieved in the following way. Assess the factors for difficult back mask ventilation. Look for the presence of facial hair, obesity, being edentulous, advanced age, and history of snoring. Dentition should be assessed and dentures should be removed before intubation. However, dentures may be left in place for non-invasive airway management. Assess the mouth opening. Ask the patient to open their mouth completely. Normal mouth opening is 3 to 4 fingerprints or patient's own fingerprints and Malampati grading. It is used to assess the size of the oropharyngeal cavity with respect to tongue size. So this is the fundamental point that we are seeing with the Malampati grading and predict the ease of the endotracheal intubation. Neck movements, flexion and extension. This testing method is also known as Deligan test. Ask the patient to flex and extend the neck. It can be graded in the following manner. Chin above the occiput in extension, normal. Chin at the level of occiput, mildly restricted. Chin below the occiput, severely restricted. Assess the thyromental distance. Distance between thyroid notch and mental prominence in neck extension. More than or equal to 6.5 cm, easy laryngoscopy. Thyromental distance. 6.5 to 6 cm, laryngoscopy may be difficult. Less than or equal to 6 cm, difficult laryngoscopy. Assess the neck circumference. The intubation becomes difficult if it is more than 42 or equal to 42 for males and more than equal to 39 centimeter for females. Cormack-Lehane grading. For laryngeal view by chest laryngoscopy, by direct laryngoscopy. Causes of difficult airway. Unanticipated as well as anticipated difficult airways often make the anesthetist sweat because of the fear of losing the airway in case of failure. Proper evaluation to assess the level of difficulty and corresponding preparation avoid such situation. Difficult mask ventilation. It can be remembered by the mnemonic bones. B for bear, O for obese, N for no teeth, E for elderly, S for snorers. The CL grading, that is Cormack-Lehane grading. Grading 1, you will find full glottis is visible. 2A, partial glottis is visible. 2B, only arytenoids seen. 3A, epiglottis liftable. 3B, epiglottis not liftable. 4, epiglottis not seen. Difficult supraglottic airway. It can occur due to restricted mouth opening, restricted upper airway, and stiff lungs with poor compliance. Difficult intubation. It can happen in case of limited mouth opening, thyromental distance less than 6 cm, retrognathia, micrognathia, and cleft palate, thyroid swelling, submandibular abscess, or hematoma, obesity, protruded incisor, and cervical spine injury. Difficult airway, surgical airway. It can happen due to coagulation abnormality. Agitated patient and flexion deformity of the neck and vascular lesion at the site intended for tracheostomy. Here I come to the end of today's session. The next video will come in the next session. Thank you.